Welcome back, clinical problem solver, to another Rafael Medina subspecialty virtual morning report. My name is Hui Tin, and today our session will be focusing on pulmonary and critical care medicine. I'm so thankful for our guest to join in today because this is the last subspecialty episode for 2024. How exciting is that I'm so grateful to be part of the subspecialty team. And of course, I'm so grateful for everybody who's joining today because this is not possible without your support and participation. So without further ado, we have as our case discussant, Dr. Paul Bergl, and as our case presenter, we have Meghan Nothem. So they're gonna do each other introduction because they have been working together. And also maybe you can share a memory or two of the time you've been, working together in a case or something like that. Welcome.
Do you want to start, Dr. Bergl?
Sure. Well, I guess I can introduce you, Meghan. So Meghan
Yeah.
has been a fantastic mentee and friend along the way here. She is originally from Franklin, Wisconsin, which is where my wife is from, coincidentally, and went out to Colorado. But we were very fortunate that she came back to the Milwaukee area after going to medical school and joined the Medical College of Wisconsin for her internal medicine residency, which is where I met her. And she went on to be a chief resident there and is now a pulmonary and critical care fellow there, and somebody I've kept in very close touch with. I don't know if I have any very specific memory. Just we've worked on a lot of things along the way, and I've still trade emails about interesting cases and fun things that kind of come up that I see in my clinical practice. So I'm really grateful to have this opportunity to share this platform with her.
Thank you, Dr. Bergl. So Dr. Bergl, he's an intensivist at Gunderson Lutheran Medical Center in La Crosse. He's also a clinical adjunct assistant professor with the University of Wisconsin-Madison. He completed medical school at University of Wisconsin-Madison, his internal medicine residency at the University of Chicago, and his critical care fellowship at Medical College of Wisconsin. That's where we met. He has served as basically my primary mentor, I should say, throughout the way. He's my main inspiration to apply to critical care. The rounds with Dr. Bergl were always just so fun, so funny, lots of laughter, but also serious when they needed to be. And I honestly can say that I truly learned the most from Dr. Bergl, and the way that he teaches, it just sticks. So, and that shows, he's a decorated educator, dozens of teaching awards. I think he won most of the years when he was at MCW. So thank you, Dr. Bergl, for everything you've done.
Wow, it is so great to see you both introducing each other. And with that, I think we are expecting an amazing case. And of course, we are so excited to hear about Dr. Bergl teaching. So I'm very excited, and especially because I'm here one of the my ICU rotation. So this will be something that I may use it tomorrow. So let's see, we have today Raul, who's going to help us describe the case, and Himun also, she is helping with the teaching points. So whenever you guys are ready, you can deploy the whiteboard, and then we can start with the case. Okay? Whenever you're ready, Raul. Okay, I think, yes, we have the whiteboard. So Megan, whenever you're ready, you can start with the first aliquot.
Sure. So we have our patient. He is a 50-year-old male. He presented to our emergency department via EMS after being found unresponsive by his family members. Last known well approximately 1 to 2 hours prior, when he left to use the restroom. Would you like further information at this time?
Well, I would love further information, but I guess I can riff on this already if you want me to. I mean, I think the initial syndrome that just, comes to mind is this a primary neurological event, or is this some sort of, circulatory shock or hypoxemia or metabolic disorder or something that's leading to, acute neurological failure? It's helpful that we have the last known well 1 to 2 hours prior, because that sort of classifies as acute to hyperacute, and that really narrows things down. I mean, from a primary neurological standpoint, things like, stroke, subarachnoid hemorrhage, seizure with postictal state kind of jump to the forefront. And on the other side, if he's still unresponsive, I guess we'll need some vital signs and things, but you sort of think about metabolic disorders, hypoglycemia, some form of circulatory shock, which has many flavors. So yeah, definitely need to hear more. I mean, there's going to be a lot of information in the EMS report about what's found on scene, what the vitals are like when they show up there. Is he breathing or not? What are the strength of the pulses? Some of these things get lost in translation, the more handoffs that occur, but I often find that with a lot of these cases, you need to trace back to this very inception of the case to really nail the diagnosis.
Yeah, I believe that Dr. Bergl, you have really, I really like the way that you're laying out the first initial presentation and the timeline of the presentation, including your differential diagnosis. And of course, now before Meghan continue with the presentation, is there any key question do you have in mind to ask when, for example, when you're resident or fellow, when they call you like, oh, Dr. Bergl, this is a patient with some change in mentation or unresponsiveness. What key question would you ask them when you're trying to admit this patient?
Well, I know when we're doing in these situations, a lot of things perhaps are still hidden, but I mean, a lot of things that we just talk about routinely, past medical history. I mean, a medication list is probably something I'll be reviewing on rounds as somebody's presenting this case just for the sake of efficiency. Previous known substance abuse problems or things like that also come to mind. And then again, I guess just sort of description of how well was well, 1 to 2 hours ago, was this person perfectly normal and at their work? Or was this person smoldering with some sort of illness over the last couple of days? And now that the family thinks about it, oh yeah, they were kind of a little bit off yesterday, or they were slurring their speech yesterday. So some of those are some clues that often come up in the history that you get collateral information that really helps you kind of hone in on, is this something that just happened, or is this something that's been brewing over the last few days? And then I think like just the description of how people found them afterwards, the level of impairment. Is it completely unresponsive? Is there some groaning? Is there, just kind of get a sense of like, maybe a Glasgow coma score, or other sort of general neurological status, because that would sort of help me figure out what to prioritize too. Clearly, if somebody's completely unresponsive, then they need the basic stabilizations of ABCs. If they're just kind of out of it and but groaning, that sort of helps give you a little bit more time and could probably cast a diagnostic net before you start jumping to a bunch of interventions.
Well, thank you so much for that explanation. So Meghan, please continue to give us more clues about the case.
Okay. So family noted that he had been in the restroom for nearly an hour. So that's the time that they decided to check on him. And this is all per the ED notes right now. This is what I'm, learning when I'm first seeing the patient. So they reportedly found him seated on the toilet and stiff. So on arrival of EMS, his SpO2 was 86% on room air. It was noted that he improved his saturations with oxygen. It didn't say how much oxygen or how high the saturations got, unfortunately, but it was noted that he was just not responsive.
Well, a lot of bad things seem to happen on the toilet. I don't know what it is about going to the bathroom. I think for some reason there must be some sort of parasympathetic tone that increases when people are feeling unwell and they feel like they have to void or something before something like this happens. But a lot of these things happen in this situation. I guess there's a couple things that I just would point out. Sort of being seated on the toilet, if they're straining, makes you worry that patient was hypovolemic or has maybe aortic stenosis or some other sort of preload dependent state that cause them to develop syncope or something. But it sounds like he's still sitting upright and stiff, which is a weird presentation. And I'll just say that the SpO2, while it might impress people, and it certainly should, I mean, it's definitely, the patient has hypoxemia. This is also a final common pathway of anything. So when people have poor circulatory, if they're like in shock, for example, the SpO2 will fall just by nature of the fact that the venous oxygen saturation is critically low. They may not be effectively ventilating. So it may not even suggest a primary respiratory problem. It may just be a final common pathway of something like circulatory shock or, a neurological failure leading to impaired ventilatory response or something like that. So it still doesn't help. I guess we still need a little bit more details.
Yeah, of course. I think Megan, you can give a more clue, more information. So maybe some past medical history of the patient. So Dr. Bergl have more to talk about.
Sure. So the patient's last HD run was 2 days prior to arrival. Further history was gathered from family members following admission to the medical ICU from one of our dedicated nurse practitioners. Per the patient's son, patient was in usual state of health at home. Baseline is ANO times 4. He's ambulatory, but he had been awake most of the night before, coughing up mucus in the bathroom. On the date of admission, so earlier before he came in, before EMS was called, he went to the bathroom around 13:30. The son and other family members continued to check on him intermittently as he was having these coughing fits. Around 15:30, he was no longer responding to questions, and he was found sitting on the toilet with limbs stiff and posturing. He was still able to track voices with his eyes. However, he had some intermittent eye fluttering, is what they said, some grunting as responses to questions, but he wasn't actually formulating sentences. And this led his son to say, "Hey, we should call EMS." And that's when EMS arrived. Should I give a little other past medical history?
This is interesting. I mean, I don't know. I mean, at this point, you tell me dialysis patient, and already some things jump to mind, and like my system one reasoning, which is, dialysis patients commonly have, infectious syndromes that present very atypically. They don't mount a fever or strong inflammatory response. I've seen patients with, raging, Staph aureus bacteremia, and the only symptom was that they got mildly hypotensive during the run of dialysis. So, I mean, I guess as one of the commonest acute syndromes we see in an ICU, and certainly something that requires timely recognition, early treatment. I guess now I'm starting to think, okay, dialysis patient, is this some sort of weird presentation of sepsis, or sepsis driving other organ failures that's contributing to this with, the coughing up mucus, common things being so common, right? That this patient's been harboring pneumonia for the last couple of days. The coughing fits, though, do affect intrathoracic pressure, right? So as somebody coughs, there is a significant increase in intrathoracic pressure. So again, that might, some of the preload dependent cardiac lesions might lead to syncope in these situations. Patients with RV failure, similarly, when they Valsalva or cough, they will tend to have, sort of rapidly descend into circulatory shock. It's the whole syndrome, though, is still a little bit weird. I mean, the fact that he's able to hold himself upright on the toilet makes me still wonder, is he having some ongoing sort of partial seizure or something? It doesn't fit cleanly. And I guess, again, I still would need some vitals and things on arrival beyond the SpO2 to help me try to characterize this syndrome more. But because all I still kind of have are, CVA, which is common in dialysis patients, stroke, already said that, sorry, bleed. A lot of these patients are on, anticoagulants for other cardiovascular comorbidities, press, because these patients have rapid fluctuations of blood pressure sometime. Seizures from any number of meds he could be on that may not be dosed appropriately for a dialysis patient. I don't know. So, and then a whole other host of metabolic disorders, circulatory shock, toxidromes, and things that could present like this.
Well, let me give you a little more. So other past medical history, he's ESRD on HD, as you know, anemia of chronic disease, diabetes type 2, anxiety, hypertension, hyperlipidemia, peripheral neuropathy, allergic rhinitis, and chronic pain. And I'll tell you that the review of systems was unable to be obtained due to his condition. Other history, should I give you that now?
I'll just defend myself and say dialysis patient. I mean, that's, like for those of us that don't do this every day, this still simplifies as dialysis patient. These are often the common comorbidities that travel with this. It's the most common pathway by which people develop dialysis dependent kidney disease in this country, is a combination of hypertension and diabetes. So, my system one reasoning was speaking loudly in my ear. This patient probably has these sort of comorbidities, and it's helpful to have them laying out here, because certainly there are other pathways to end-stage renal disease that would affect the differential diagnosis. But yeah, it's still just a dialysis patient in my mind, is how I still simplify it.
All right, so let me give you a little more. So family history, diabetes in his mother and father, maternal grandmother and maternal grandfather, and paternal grandmother. So a lot of diabetes. Hypertension in mother and father, and his father died of heart failure. Unclear as to which type. Social history. He was previously married. He's divorced. Previous smoker, but really not super significant, at least from my pulmonary standpoint. Just a few cigarettes a day for 19 years, roughly 2-pack years. Quit 20 years ago. Previously used chewing tobacco, but very rarely. Quit that 20 years ago. No vaping, no alcohol or illicit drug use. As I said, though, this is per the chart in the patient's family right now. I can give you some medications. So Tylenol, just as needed, 500 to a gram, the usual stuff. Amlodipine, 10 milligrams. Vitamins, just a B complex and a folate. Vitamin D. Clonidine, 0.1 milligrams oral twice a day as needed, and mentioned at dialysis for that. Furosemide, ferric citrate, gabapentin, hydralazine. He's on 100 in the morning, 50 in the afternoon, and then 50 at night. He's on glargine, 10 to 20 units daily. He's on loperamide as needed, meclizine as needed, omeprazole, 40 milligrams a day, ondansetron, 4 milligrams as needed for nausea, rosuvastatin, and Veltessa. Allergies, none. So I'll stop there before the exam.
Help me out. I don't
Yes,
speak brand name. What's Veltessa?
I looked it up before this and I had to look it up
Is it like a
again.
calcium? Is it like a phos binder or something? Or
Yes, I think that's what it was.
I think we have it
well,
right there. Zirconius, potassium binder.
oh,
Yep.
okay, all right, yeah, okay,
Mhm.
excellent.
Thank
So
you, sir.
well, a lot to
Yeah, I
reflect
have
on.
a
I also
question
want to acknowledge some
actually.
of the comments. I think there's a couple things
Yeah.
like I think that well, let me talk about the med list and I'll kind of speak to a couple of the comments too.
Mhm.
This is sort of what I expected, although patients with end-stage renal disease kind of have variable levels of hypertension, and then as the disease progresses over time, often have persistent hypotension. But I would come back to maybe that press would be a consideration, more often seen in women, I think, than men, if I had to remember the probabilities correctly, seen with certain comorbidities like connective tissue disease, patients on immunosuppressants. But certainly, like if one of the pathophysiologic insults that leads to press or posterior reversible encephalopathy syndrome is just a massive surge in sympathetic tone, and then probably a breakdown in the blood-brain barrier in the posterior circulation. For whatever reason, that's more vulnerable. So that could fit because you have a patient who is on multiple antihypertensives, probably has big blood pressure swings during dialysis sessions when the circulating volume is rapidly shifting. If he misses a dose or two of clonidine, he goes into clonidine withdrawal. I'm not sure if this PRN dosing, I guess you have to kind of wonder how he's really taking it. So I guess I would put press on the list now of things that could just cause encephalopathy or could have caused seizure or something. And then I guess the other thing I'll say is that this dosing of glargine, 10 to 20 units, again, I'm not sure how he's doing it, and that we still haven't heard that he's got, had a glucose checked. So that could all fit. Somebody was commenting on the neurological exam being interesting. I'd still like to see more of it too. I guess I'll just say that doing this long enough, I've seen all sorts of goofy things. And I mean, a lot of this could still be like just somebody in a low cardiac output state and the brain just isn't doing normal things. So the grunting, the eyes fluttering, that could be a sign of ongoing seizure or focal partial seizures, but I'm not sure. And I see somebody shouted out gabapentin. Yeah, this is a drug that has been used a lot in this country now especially as we became very opioid-phobic. And I'll tell you, it's probably one of the top 3 or 4 drugs I see as complicating somebody's ICU admission. I mean, there's an awful lot of gabapentin-induced encephalopathy and buildup that occurs when people develop acute kidney injury. I'd like to see the dose he's on in end-stage renal disease, because if it's more than 100 or 200 a day, and he's taking it more as needed or something, there's just an awful lot on this med list to pick apart. I mean, there's some anticholinergic properties in there too, so you wonder about just sort of an anticholinergic syndrome. So this really helps flesh it out. I'm sort of obsessing over the medications, but if this ends up being more an encephalopathy case than anything else, then 7 to 8 times out of 10, there's probably some role that the medications are playing in it, from my experience.
Yeah, the gabapentin was 600 nightly. So whether or not he's taking it that way was unclear. Any other thoughts from anyone else? Otherwise, I'll do the physical exam.
Yeah, I think it's
Yeah, I
that's the
believe
one he's
so.
going to be here now. I mean, he's really trying to figure out, is this a primary neurological syndrome? Is this a primary toxidrome? Is this a state of, circulatory shock or respiratory failure with the neurological manifestations being most prominent?
Sure. Okay, so on
Mhm.
arrival to the ED, temperature 88.5 Fahrenheit, which is 31.4 Celsius, blood pressure 130s over 70s, heart rate 60s to 70s, respiratory rate 16, SpO2 was 82 to 86% on room air. Our patient is 72.4 kilos, 5'5", and sometimes we say that this is another vital sign. I'll just tell you right now that his glucose was 175 point of care. General exam. So he was opening his eyes to the providers talking with him, but really not responding. No response to pain. Not speaking in sentences. Um, he was normocephalic, atraumatic. Mucous membranes were noted to be dry. His pupils were equal, round, and reactive to light. Uh, Cardiac wise, regular rate and rhythm, no murmurs, normal pulses. For pulmonary, normal respiratory effort, normal breath sounds, no wheezing, no rales, so pretty non-contributory there. Abdomen was soft, no distension, no tenderness noted. For MSK, no tenderness, deformity, or signs of injury. No edema noted in his lower extremities. He does have a fistula in his right upper extremity. There's a palpable thrill, which is expected and normal. Skin was warm, dry, no rashes. For neuro, his GCS was 9. As I said, no verbal responses other than just some grunting, really not making sentences, not making sense. Withdraws to pain, as I said. Eyes open, but does not blink to threat. And then I'll say that he was intubated down there in the ER for the GCS of 9 and saturations of 86.
Oh, this
Basically
is
airway protection.
Yeah, this is so fun. This has become more fun. I mean, this was already fun. Yeah, I mean, so like you sort of have to assume that this is not a man found down in a snowbank. And so this is, to me, I kind of have my own working way of approaching non-exposure related hypothermia, which is to say somebody in a normal room temperature environment that becomes hypothermic. I mean, there's sort of, you can think about it mechanistically that the hypothalamus is what regulates body temperature. So you need sort of an intact hypothalamus. And then down the spinal cord, you need the peripheral nerves to be able to respond appropriately. So, patients like this who have, autonomic failure from multiple reasons, longstanding diabetes, et cetera, may already have difficulty in regulating body temperature and, inducing vasoconstriction when another insult comes along. So, and then you can sort of think about common syndromes that cause this. So like sepsis is a big thing. Always think about sepsis in a dialysis patient who's hypothermic. Any low cardiac output state will do this. So if somebody is really hypovolemic or if somebody's in cardiogenic shock, there's just going to be poor perfusion overall. And it's, sort of downregulation of metabolism, poor skin surface temperature. Now you said the skin was warm, so that's a little bit weird. That could just be because the patient's now been in an environment or it was somebody decided to put them under a warmer or warm blankets or something and sort of affected the physical exam. Liver failure is commonly implicated in hypothermia just because those patients usually have a state of inappropriate vasodilation from their liver failure. The fact that the glucose is normal now to me doesn't exclude that it was abnormal before and somebody gave him dextrose. I've definitely seen very significant hypothermia after people had symptomatic hypoglycemia complicated by neuroglycopenia. Other endocrinopathies I think people are throwing around in the chat too, or it's really bad thyroid state. Usually, if you're going to see that though, like this patient would have a heart rate of 30, and really prolonged reflexes and things like that would go with it. So it's something obviously you need to remember. Similarly, hypocortisolism, primary adrenal failure will cause a loss of sympathetic tone, which will lead to loss of body temperature. There's a couple other things I guess I threw out there. Again, I have seen hypothermia in the context of seizure, and presumably that's because the hypothalamus is implicated. This is more common. Hypothermia is more common, I think, in people that have had previous strokes or have dementia or neurodegenerative diseases, because I think they just probably don't have as much, hypothalamic mass. And then the last thing is, like sometimes medications can do this again, usually probably by inducing peripheral vasodilation or nutritional. So it's, I think it's described in maybe like a certain percentage of patients with Wernicke's encephalopathy. The hypothermia is a prominent feature of it as well. And again, that's probably a peripheral neuropathy, or autonomic failure syndrome. So that to me is super interesting. I love the hypothermia. It's probably so I guess after all that whole long thing, sorry, I would go back and say, like, am I sure this patient is not in a low cardiac output state? That's the first thing that you'd sort of make sure that's just not, it's just, not a sign that they're hypoperfusing. And then after that, you kind of can use it maybe as a pivot point for working through these other possibilities. Still wonder about seizure. I'm glad they protected the airway, just because the patient has intact motor responses. I've been fooled that patients actually can have, sort of ongoing status or in and out of status and have intermittent motor responses to pain. I don't want to take that home with you, but I've been fooled by that too. So that's still a big concern here, is ongoing seizure, bleed, things like that we need to kind of work through the primary neurological problems. In fact, I think I'd cut down the neurologic pathway at this point, based on what you've said so far. The clinical exam really does not speak to a low cardiac output state, but there's still a large differential.
Yeah, exactly. I think at this point, do you think that any of the past medical history of the patient could explain to his present illness, or are you thinking about more medication induced? What are you thinking now?
Well, I start to think shortcuts. So I think I sort of need like a neuroimaging to sort of make sure not bleed, not not big stroke. And then I guess I would say I'm kind of, if that is normal, then I think the next step would probably, in my mind, be trying to get some sort of, stat electroencephalogram or point of care encephalogram that can rule out status epilepticus while we're waiting for labs and things to be cooking. This could all still be, a lot of the other things are just going to be supportive care in terms of and then I guess I treat them empirically for sepsis. But I mean, those are the things that kind of need to be done in the next hour to two, or the diagnoses that need to be excluded or evaluated in the next hour or two. And then you could sort of have in the back burner the chronic, peripheral neuropathy, the medication induced, endocrinopathies. Those are, the endocrinopathies can be life threatening, but there's a handful of things that are even more threatening, I think, to kind of work through quickly in the next hour or two.
And Dr. Bergl, I'm interested to know what are your thoughts about now this patient. If we think about sepsis, would you start with what would be the management for you? Would you start with empiric antibiotics, steroid? What would you do at this point?
Oh, this is like Pandora's box. I mean, this is one of the most challenging things I do every single day, which is trying to figure out who is septic and how broad to be in this spectrum of antibiotics. I mean, I think this is sort of this is a community dweller with frequent healthcare exposures and a fistula that is repeatedly being accessed. So I don't think there's nothing about this history that says you need anaerobic coverage. So if you said ceftriaxone and Vanco, or you said cefepime and Vanco, I think you probably got yourself covered. I think you'd want to cover, primary bacteremia and somebody that's repeatedly cannulated. You're going to get it wrong sometimes with your empirical choices, but I would empirically treat, it's a life-threatening diagnosis. The longer you wait, the worse off you are. There's at least a couple. You got the hypothermia, you got the brain failure if that's part of this syndrome. It's kind of hard to fault somebody for giving them a dose of antibiotics while they're working through, is this sepsis? And sure, if we find it's something totally different, or we conclude this is, viral encephalitis or press or something else like that, we'll figure that out in the next 24 hours, and we don't have to continue the antibiotics. But I would empirically treat, just because from my own experience, I've been burned before. I'm like, intermediate probability. Let's kind of work through some other possibilities. Just give a couple doses of something which will based in the patient's system for 24 hours while you're working through everything else.
And just a following question, Dr. Bergl. So let's say that this patient here is his blood pressure is 130/70, but if the patient was hypotensive and he's in shock, can you guide us through what would be the pressure that you will be starting with and why?
Yeah, I mean, sure. Hands down, norepinephrine is your preferred pressure, actually, in really any shock state. It's probably the best safety profile, the best track record. That goes even for cardiogenic shock. So, yeah, I think then the fluid management becomes difficult in an end-stage renal disease patient, and wondering whether or not they're going to be fluid responsive and or fluid tolerant, which are two separate issues. How well will their cardiac output augment with a fluid bolus? and how many times can you give that and augment cardiac output without having the adverse consequences of things like third space fluid into the lungs and whatnot. So that's a whole nother topic. But yeah, I think, the norepinephrine is still the preferred vasopressor really for any shock state. And if you're not sure, just start them in norepi while you're kind of getting additional data, hemograms, invasive lines, echocardiograms, whatever else it takes to clarify the shock phenotype.
Great, thank you so much for that. So Megan, please continue with the next aliquot.
Sure. So now we have labs and imaging. So our venous blood gas, 7.34, 48, and 48. So PO2, PCO2, both 48. And then bicarb 26. SpO2 was 75 on that VBG. Lactic was 1.3. Our CBC with diff, so our white count 10.1. Hemoglobin 11.4. Hematocrit 35. MCV 105. And you let me know if I'm going too fast and you can't get this all down for the scribe there. MCV 105, I think I said that. Platelets 268. 84% neutrophils, 7% lymphocytes, 7% monocytes, 1% EOs. So for our BMP, sodium 133, potassium 4.4, chloride was 91, bicarb was 20, BUN 58, creatinine was 9.15, but keep in mind this is a dialysis patient, so that's going to go up and down. And then our glucose was 164, and our anion gap on that was 22. Calcium was 8.2 on that, but our ionized was 1.03. So the normal range in our lab is 1.18 to 1.33. Hepatic function panel. So our albumin was 4.2. Our protein was 7.2. Our ALK phos 73. AST 22. ALT was 14. Our Billy was 0.3. And our direct Billy was less than 0.2. Our CK 295. Beta hydroxybutyrate of the blood was 1. And our normal range in our lab is 0.1 to 0.27. INR was 1.2. Must make a tiny bit of urine because they were able to get a UA. So it was noted to be dark brown and turbid. Glucose on that was 150. Billy negative, but ketones of 20. Specific gravity 1.016. Greater than 1 blood, pH of 7.5. Protein 300. Urobilinogen was normal. Nitrites were negative. Leukoesterase was 250. Greater than 100 RBCs. And 26 to 50 WBCs and some bacteria present. They did get a Tylenol or acetaminophen level less than 5. Salicylate 1.5, so that's normal in our lab. Phenol was within normal limits, undetectable. B12 was 348, that's normal. Folate was 13.1, that's normal. And then UDS, so it was negative for amphetamines, cannabinoids, cocaine, fentanyl, opiates, barbiturates, benzos, methadone, oxycodone, and ethanol. Let me know if you need me to repeat any of that in the lab section. I went pretty fast. Do you want to make any comments now, or should I go through some imaging?
Well, no offense, wholly unhelpful largely. I mean,
Yeah.
sort of, like as long as the sodium's normal, the calcium are normal, there's not a big, metabolic cause. A lot of these things are sort of what you expect with an end-stage renal patient. Somebody commented that the albumin's a little high for an end-stage renal patient. It's fair. I mean, they may be a little bit intravascularly volume depleted, but and the MCV, I guess, could be high for, I don't know, other reasons. I mean, I don't know why a 50-year-old would have like a myelodysplastic syndrome, smoldering, or some other sort of micronutrient deficiency or something, or a reticulocytosis with a bleed or a hemolysis or something. So I guess it's a little interesting, especially with the normal B12 and folate, but this syndrome is too acute that I guess I wasn't terribly worried about one of these, one of those two things being a big problem. Yeah, I mean, and the gap of 22, and that's probably just the fact that he's a renal, a patient with end-stage renal disease and has a lot of inorganic acid building up in his bloodstream with a mild fasting or diabetic related ketoacidosis here. But yeah, overall fairly unimpressive. I guess it sort of helps rule out that he's not hypoventilating. The white count's not 50, which makes you sort of, like 10 is just in between. I guess he could still be infected as a patient on dialysis. And the rest is just kind of like, that's about what I would have predicted if you had asked me to make up a bunch of labs for this patient.
All right. So for imaging, what we all wanted to know, the CT acute stroke head without contrast showed no acute intracranial findings, no hemorrhage or large territory infarct. Chest x-ray showed bibasilar patchy opacities. They said could represent infectious or inflammatory process in the appropriate clinical setting. And they just measured where the ET tube was. So that was an appropriate position after intubation down in the ED. And then they did proceed to obtain a CT acute stroke angio head and neck with contrast. So that showed no large vessel occlusion, but significant greater than 50% stenosis. No significant stenosis, dissection or pseudoaneurysm. So it was all negative. And then the KUB, really didn't need to mention that, but just non-obstructive bowel gas pattern.
Dr. Bergl, going back to the labs, with the high anion gap metabolic acidosis, do you have any differential diagnosis? I know that we have some very common mnemonic for that, piled. Would you like to tell us more and describe them for you? And if there's anything in this patient past medical history besides the end-stage renal disease that could explain these symptoms?
Yeah, I kind of blew through that, but I guess I didn't, so you could use mud piles or gold mark. I just combined two of them. The advantage of gold mark is that it has the oxaproline toxicity, which is a metabolite that accumulates particularly in older women who are undernourished, who are chronically taking acetaminophen. So it's a chronic metabolite of acetaminophen. And I've seen probably 2 cases in about 8 years of just doing critical care, basically. So not very common at all. The nice thing about gold mark is it says renal failure and mud pile says uremia. And it's actually the renal failure that leads to the widening anion gap. And it's because you have a certain level of dissolved organic acids, like your phosphates and sulfates, that start to circulate in higher levels when patients have end-stage renal disease. So you can use the serum phos as a rough marker of how much inorganic phosphates might be circulating as well. But that is usually the culprit in these patients. There's a little bit of it that may be accounted by the beta hydroxybutyrate. You've already taken lactate off the table. Just riffling through the rest of the gold mark, the G is glycols. We didn't hear any good history for that. The cases I've seen, people can be surreptitious. People can be sneaky about it, but usually these people have massive elevations in lactate, huge anion gaps by the time they show up encephalopathic like this. So this is not a toxic alcohol case. I can just tell you that. I mean, if I'm wrong, I'll eat my words, but I almost certainly this is not a toxic alcohol case. Similarly, methanol doesn't tend to elevate the lactate nearly as much, but they're talking about massive elevation in anion gap, like 30 plus, by the time the patients come in, encephalopathic and show up at your doorstep, usually. And you would need a serum osmolarity for both of those things to be sure. What else am I missing? The D-lactate almost never happens. I've never seen it. The aspirin, we got a salicylate level, not the issue here. So we're, pretty quickly down to just the renal failure is driving it. And for somebody who deals with acid base basically every single day, all the time, I'll give a pass on this. This is an anion gap of 22 and somebody with a normal albumin of 4.2. That's passable. It's probably just explained by renal failure, and it didn't really catch my attention very much, particularly since we heard the lactate was okay. The beta hydroxybutyrate wasn't terribly impressive, and nothing else about the case made me start really kind of going down the toxic alcohol pathway, which would be sort of the next big alarm thing that would go off in my head.
Dr. Bergl, a following question. So you mentioned the serum osmolality, and in the ICU, we are commonly asked about the osmolar gap. Would you like to tell us when do you use it? What is the normal or for you? And then how do you interpret those results?
Yeah, I mean, the osmolar gap, you know, just basically take the measured serum osmolarity, and then you take the BUN, the sodium and the glucose, and get a calculated osmolarity. And a gap is defined as anything greater than like 10 to 12. There are not a lot of things that cause a significant osmolar gap. And the toxic alcohols are one of the biggest things. And usually talking like 30, 40 in the cases I've seen over the years. So ethylene glycol and methanol and their metabolites are soluble. I guess they have a certain level of osmolarity, and they create this osmolar gap. Isopropyl alcohol does as well, but it does not cause an anion gap. So that's one trick to remember. The other things that can do that, though, that you need to remember is just when patients are in DKA, they will get an osmolarity gap because of the acetone. So the acetone that builds up in addition to the beta hydroxybutyrate causes a widening of the osmolar gap. Another thing that to be aware of is that ethanol also causes osmolarity to go up. So if you punch it in an online calculator, you have to make sure you have a measured serum ethanol level. I'll never forget one time an intern called me and said, "Oh my God, I have a patient who needs dialysis. They have an osmolarity gap of 40." And I said, "Your patient's just intoxicated. Look at the serum ethanol." So, you know, that's a big thing that goes into it as well. The last thing I'll say is that it gets checked often enough that the powers that be say anything above 12 or whatever is pathologically abnormal. When people get really sick, there's this phenomenon called sick cell syndrome, which I can't find a good explanation for. But if people are in bad shock and all their organs are failing, the osmolarity can rise. And it's if you look it up look it up in up to date, or you find a review article on this, they'll call it sick cell syndrome. And nobody's really sure why that happens. But again, like I give an osmolar gap of 20, I'll usually pass that over if there's not a really good reason to suspect something else going on, especially if the person's really sick.
Oh, amazing. I think I learned just now something new today, the sick cell syndrome. So I would look into that.
It only took
So
43 minutes
Megan,
to teach you something. Wonderful.
among everything else, I think I've learned so much already. So Megan, please give us more details about the case.
Sure. So other labs in advanced imaging. So echocardiogram was performed, LV normal in size, normal left ventricular systolic function, LVEF 58%, LV mass index to body surface area and based on gender was moderately increased. RV mildly enlarged in size, normal RV systolic function, LA mildly enlarged in size based on measured volume index to body surface area, RA mildly enlarged, moderate to severe TR, and the estimated PASP, so the pulmonary artery systolic pressure, was severely elevated at 61. Other labs. Ferritin was 1,465, so that's elevated. Iron was 44, low. The TIBC was 217, that's low. Intact PTH was 209. Vitamin D 20.2, that's normal. Phos was 4.5, and Mag was 2.2. Pneumonia panel, which I believe was obtained as a tracheal aspirate after intubation. So that was our biofire. So that checks for bacteria and common bacteria, common viruses that cause pneumonias. That was negative. The respiratory culture showed 3+ PMNs, 1+ gram-positive cocci. And the serum osmolality was 347.
Oh man, you're gonna make me eat my words, huh? 347?
Yeah. And so
Okay.
if we calculate that, so with a measured serum osmol of 347, when I calculated the serum osmol, that was 296. So that gives us a gap of 51.
Holy moly. All right. Well, there's I mean, the good thing you measured it, because I would have kind of brushed it over. I mean, this is all right. Well, you know, everything else can just be kind of ignored. I was going to talk about this echocardiogram doesn't really tell you a whole lot, but blah, blah, blah. Yeah, I mean, so we kind of just talked about the differential diagnosis for this. I mean, this is a massive osmolar gap. And the problem with toxic alcohols, is that these trajectories change. So, man, I wish I was a toxicologist because it depends where you intercept the patient. If the patient has just ingested and they're just intoxicated with it, the osmolarity will be very high, but the gap, the anion gap might not be. And as time progresses on, these will flip, and I believe the osmolar gap will start to diminish, and the anion gap will continue to climb. And if I'm getting that wrong, I'm sorry. I'd have to look it up to just be sure. I've seen probably nearly 10 cases now of ethylene glycol poisoning over the years, and probably 2 methanol intoxications. And as I said, they're always weird stories. The last couple ethylene glycols I've had in the last few months were, one guy, sort of told his wife, so that was easy because he was trying to kill himself. The other was an old elderly woman who had, underlying depression and just came in with a lactate of 25 and a pH of 6.9. This would be a very impressive catch early on if that's what this ends up being, but there's not a whole lot else to blame the osmolar gap on. You'd really have to say that this is probably a toxic alcohol, because I just went through all the other stuff. You have a serum ethanol level, which is normal. The patient is not in fluoride decay, so there's not just a massive amount of acetone accounting for that. So I'd have to believe the patient recently ingested methanol or ethylene glycol, and the treatments are fomepizole and emergent dialysis. I would talk to a toxicologist. I think you all are lucky if you're in a bigger center that you can send a toxic alcohol panel immediately and get rapid results. I'm in a community-based setting where those things take 24 to 48 hours to come back. So we're empirically doing this. But this, to me, hit the empirical threshold. If you think about treatment approach to disease, there's not a lot of things that do this. This is clearly life-threatening disorder. I saw a young guy die of the brain swelling from methanol intoxication. I saw another woman die of basically horrible, brain injury from ethylene glycol poisoning. So the longer you wait on those things, the worse the syndrome is. So there's not a lot else to hang our hats on now, right? I mean, this is a big pivot point. We have a negative head CT, all the other labs kind of didn't really help narrow the differential diagnosis. So we're kind of left with a toxidrome, I guess. So now I'm going to really eat my words if it's not a toxic alcohol syndrome, because I can't think of anything else that would give you the serum osmolarity like this. And thank God somebody had the wherewithal to check it.
So Dr. Bergl, talking about the toxic alcohol and talking about the management, you mentioned hemodialysis. And for example, this patient is already on hemodialysis. But in another patient who is not already in hemodialysis, what would be the indication for hemodialysis?
It's the usual thing still. So I mean, you start, when I've done this, I've always talked to a toxicologist. Just because I've done it before doesn't mean I'm an expert in it. So I always want to get, my local poison center on board with me. Fomepizole is the antidote. It competes with alcohol dehydrogenase to limit the production of the toxic metabolites that come from the metabolism of methanol and ethylene glycol. The usual indications, though, for dialysis are the usual indications for dialysis, the AEIOU. And the biggest one is usually the severity of the acidosis. So like if you have somebody with a pH of it's already 7 and they're not making much urine because they already have a bunch of calcium oxalate that's precipitated in their urine and in all their tubules, then it's the usual AEIOUs. So it's usually the acidosis which ends up prompting you to initiate dialysis. But that doesn't mean it's not give fomepizole first. And fomepizole is cleared through dialysis, so you need to work with your pharmacist and the toxicology folks to make sure you're redosing it appropriately. But yeah, this is not a patient who necessarily needs dialysis yet. I think you'd start with the fomepizole and kind of just recheck venous pH, anion gap, things like that every 4 hours or 6 hours or whatever the poison control folks recommend.
Great, thank you, Dr. Bergl. So we are kind of reaching to the end of the hour. So I'm going to give the mic back to Meghan so she can give us some of the last clues about this case.
Sure. So the volatile alcohols was sent. It did take time to come back. So I can give you that result in just a minute, but I'll let you know kind of the last bit of the course. So patient arrived to the MICU intubated, sedated on propofol and fentanyl. These were discontinued on arrival to gauge his neurostatus. He became agitated, Precedex was started. Further encephalopathic workup was obtained with a continuous EEG like Dr. Bergl wanted. That was negative. His mental status improved after hemodialysis overnight. The hemodialysis was performed just routinely because his last one was 2 days ago. So nephrology felt that it was appropriate to dialyze him. He was following commands the morning following admission to MICU. He tolerated pressure support, a pressure support trial. He was extubated. Following extubation, he did endorse an interesting history based on his chronic pain. So in line with his volatile alcohol screen, which I'll tell you now, ethanol was negative, methanol was negative, ethylene glycol was negative, but his acetone was 189 and his isopropanol was 24. So he endorsed topically applying copious amounts of rubbing alcohol to his joints on a chronic basis for pain.
Dr. Bergl, are you
You're
surprised
muted.
to
Yeah,
hear
I've
this?
not
I
seen
can
that.
see your face.
The,
Tell us,
the,
tell
the
us
only
what is
the only
going
couple
through.
of cases I've seen of isopropyl alcohol intoxication were patients that were drinking the hand sanitizer to get a high in the hospital. Which happens. And there was one patient I remember very vividly who had an opioid use disorder, another substance abuse disorder. And I got called to his bedside because he had been in the ICU with ARDS from I think like probably aspiration injury when he was intoxicated. And they come see this guy, he's acting weird. I walked over to him like, this guy just seems like he's drunk. What is the deal here? And fortunately, the PA on the hospitalist service had the idea of like, well, we should check an anion gap and a Osmolar Gap and see if he was like drinking the hand sanitizer. And sure enough, he was. So and the anion gap here is probably normal. I mean, the anion gap here is explained by the other things we already talked about, which is the end stage renal disease. So this is sort of the quintessential isopropyl alcohol biochemistry. But I cannot believe this. I did not realize you could absorb so much through just topically applying this. Has this been reported, Megan? This seems like a case report. I've certainly seen people drink this stuff, and I know about that, but wow.
Yeah. Yeah. So our toxicologists are excellent. So they wrote a wonderful note. They actually said there is a case report almost identical of a patient using rubbing alcohol daily for joint pain, but the patient was on HD. So intermittently, this would be dialyzed, the metabolite. So this resulted in delayed toxicity, similar to our patient, we thought. So, but following prolonged dermal exposure, maybe it was that this patient was ill with some form of pneumonia, who knows? But this time, he presented with the symptoms, and similar to that case report that they spoke of in their note, the patient also presented hypothermic and with CNS depression. So it has been documented. It's extremely rare. Also, the patient this was nowhere in the chart actually until a later admission, but the patient's also legally blind for what it's worth. So I don't know if that had anything to do kind of with him, kind of looking around strangely in the ER as well.
Yeah, I guess there's one last
Wow.
comment here about like why was he stiff and stuff. I don't know. I just hear about so many stories of people that have neurological syndromes and encephalopathy. There's all sorts of weird stuff that happens, and it's hard. Like when it's clearly a hemispheric stroke, great. If they're clearly obtunded and seemingly post-ictal and doing nothing, great. And this other stuff is all in between. But I guess yeah, the hypothermia, all that, it's just intoxicated with the stuff. It's just basically like any other alcohol, right? I mean, it sort of causes vasodilation, it causes CNS depression, and the clue here was that this massive osmolarity gap, which fortunately our ER colleagues check frequently when people come in with unexplained encephalopathy, right? It's a good thing they do, because this is it is a kind of a screening test when somebody comes in smelling a little bit like a toxidrome. So kudos to them. I mean, I don't know if I don't know if I would have arrived at that as quickly if somebody hadn't supplied the osmolarity gap. Just to be totally honest here, I would have probably gone more towards this is a medication toxicity. This is nutritional. There's some combination thereof, and the patient just sort of needs some time.
Yeah, it
So
was a
Dr.
big
Bergl.
kudos to our. Oh, sorry. I was just going to
No,
say
no, go ahead.
it was a big kudos to our toxicologists in the ED because they had already sent this volatile alcohol before the patient even rolled up. So that was pretty cool.
That's great. So Dr. Bergl, I can see you're surprised about this case. I'm going to give you a minute to think of maybe 2 or 3 teaching points to give us. And in the meantime, I would like to hear Meghan, how do you feel about taking care of this patient? Tell us what have you learned from this?
Yeah, I think, always keeping our patients are obviously difficult because they have so many different things going on. And, the way that you learn kind of a diagnostic algorithm with the anion gap in this case, you might think, okay, isopropyl doesn't cause an anion gap, but this patient had another reason to have an anion gap being a dialysis patient. So I thought that that was, very important to keep in mind, the multi-system nature of the patients that we care for. Also, history. I think calling the family, getting a history is super important, but obviously, as in this case, there's no history like that from the source itself, from the patient. So, had we not had these levels, who knows if we would have arrived at this, but it's not often that a patient, maybe admits to rubbing alcohol on themselves for pain, which is just interesting. It had been documented no other time in the chart, but maybe if someone had said, hey, you said you're in pain all the time, what do you do for that? I don't see really I don't see any pain meds as far as opiates on your chart. What are you taking for that? And maybe at some point he would have mentioned it and this could have been avoided. So I think history and taking care of your patient as a whole person is super important.
So
I
my teaching
agreed.
points are
I
basically just
think
going
the
to
patient,
refute Meghan.
go on.
Well, I'm all about the history, and most diagnoses come from them. But I will tell you, from the toxic alcohol cases I've taken care of, up to date says take a scrupulous history, figure out what they ingested. More often than not, you have no idea, and they come to you encephalopathic, and they're not going to tell you because they wanted to commit suicide and they didn't want to tell anybody. And it's you're doing cleanup duty afterwards, and you're like, why is the lactate 12? Why is the patient so acidemic? So usually these patients have a more advanced presentation afterwards. But I guess I would say, like, if somebody's got an unexplained acidosis or encephalopathy and there's any reason to think this, then send the osmolarity gap, make sure you get a venous pH. So that to me is like, this is one of those syndromes in the ICU that the history is often not there, and you're doing biochemistry because the patient won't give you that history. The other big thing is that I think I was kind of itching for the imaging early on. I think just for the sake of efficiency, like when I'm looking at encephalopathic patients in the ICU, I use an approach that I think probably CPS uses, as well, which is it structural, right? Is there a big thing I can see on a CT scan? Is there a bleed, a major hemispheric stroke, something like that? And if not, like, let's move on to the other things like the metabolic disorders, infectious syndromes, toxidromes, medication-induced that sort of cause the vast majority of these things as well. I don't have any other teaching points. A lot of this stuff ends up being noise. And the history ended up being crucial for making the final diagnosis. But in the heat of the moment decision-making, it's like, oh, shoot, we have an unexplained osmolarity gap. That makes no sense. And that is life-threatening. We just have to treat even if we don't know the history. So
Wow.
this is a fantastic case. This is such a great
Yeah,
case, Meghan. Really great. Thanks for sharing it.
I'm
I
so
agree
glad I
with
had
that.
it. When you asked me to do this, I knew this one right away.
That is actually an amazing case. I agree with Dr. Bergl. And now, Meghan, I can see why you said that Dr. Bergl is an excellent mentor. So I can see how the way he teach, he go through every single thing with detail, all the differential diagnosis. Even I was like, what should I ask? He's already answering everything that I have in my mind. So, oh my God. So, sadly, we reached the end of this session. I really thankful for the both of you for joining us and learning from you. An excellent case and an excellent teaching from Dr. Bergl and of course Meghan. You have brought us an amazing case and just see how you walk through the whole case. It's been incredible. And of course, tomorrow is the last day of the year. So I wish you all a happy new year. Wishing you lots of love, health, and of course, a lot of clinical reasoning for this new year. So, yeah, so thank you, everyone. And I will see you on the next episode. Bye.
Thank you.
Thanks for having us.
Bye.